So now we're going to have our talk about the upper limb anatomy with respect to the MRCSPartA. So first of all, we will talk about certain bony landmarks and we will learn that which relevant structures are very closely related to those important bony landmarks with respect to the upper limb. So first of all, with the sternoclavicular joint, the posterior structure that is present is the origin of the subclavian artery. So here in the midline, we will be having the manubrium and the sternum, and this area, which is the clavicle that it will be communicating with the sternum, will be the origin of the subclavian artery. Then two structures which are anterior to the anterior scalene but behind the clavicle. So here we have the anterior scalene muscle. This is the middle scalene muscle. Now, what are the structures which are present between the clavicle and the anterior scalene? We have the subclavian vein and the phrenic nerve. As you could appreciate, that phrenic nerve will be coming down like this, and here we have the subclavian vein, which you can appreciate. Now, which two structures lie between the scalene anterior and scalene medius? Here, you can see that this is the scalene anterior, this is the medius. So, we have the subclavian artery, which you can appreciate over here, and the roots of the brachial plexus, the 5 roots that is starting from C5 to T1. So, these 5 roots are present between these two muscles. Now, there is an important clinical correlate that if there is a fracture of the distal third of the clavicle and if there is a scenario that there is bleeding, then they are testing you that the thoracoacromial artery has ruptured. So, with respect to the deltopectoral groove, it is a groove which is present between the deltoid and the pectoralis major muscle. It contains the cephalic vein. Now, when an incision begins below the sternoclavicular joint towards the deltopectoral groove, it can result into an injury or bleeding will be from the thoracoacromial artery. Now, thoracoacromial artery from the second part of the axillary artery. So, you also need to remember that as well. Now, while this is going to be damaged, where at the shoulder joint capsule, the roots and trunks of the brachial plexus and insertion of pectoralis minor will all be safe during the incision. So basically, these are the different MCQs which have been tested in different exams, and they are added in a single file in a very precise sequence along with the diagrams to help you guide with the concepts that what type of relationships are usually tested on the exam. So now we will have our discussion about the bones. So humerus has two necks in the very proximal part. One is the anatomical neck and one is the surgical neck. So anatomical neck gives attachment to the capsule of the shoulder joint, this has been asked in the MCQ. And the surgical neck is related to the axillary nerve and posterior circumflex femoral artery. Now, axillary nerve is going to supply the deltoid muscle. Along with that, it is going to supply the teres minor muscle, and it is also going to give a sensory supply to the badge area, which is the lower area in front of the deltoid muscle. Now, posterior circumflex femoral artery arises from the third part of the axillary artery. So you need to remember all these facts about the anatomy. So further, in the upper part, we have two tuberosities. We have the greater tuberosity and we have the lesser tuberosity. Now, greater tuberosity is going to give attachment or insertion to the supraspinatus, infraspinatus and teres minor muscle. Like supraspinatus will origin on the posterior aspect from here, and it is going to come over here. Then the infraspinatus will have its insertion over here, and teres minor from here will also come to the greater tuberosity. However, on the anterior aspect, we have the subscapularis fossa, which gives origin to the subscapularis muscle, and it inserts on the lesser tuberosity. So these muscles which are present on the posterior aspect are going to be responsible for the external rotation of the shoulder, whereas this muscle which is present anteriorly, it is going to pull it towards the inside. It is going to be responsible for the internal rotation of the shoulder joint. So inferiorly, it has two epicondyles. So as you could appreciate that this one is the medial epicondyle and this is the lateral epicondyle. Now here we will be having this as the medial and this as the lateral epicondyle. So this medial epicondyle is the origin for the common flexor muscles and the lateral one is for origin of the common extensor muscles. Now anteriorly, it has significant landmarks that the bicipital groove, which is this area, which you could appreciate over here. Now this is going to give attachment to a lot of muscles. Now in the floor, there is going to be attachment of the latissimus dorsi. On the lateral lip of the bicipital, there is going to be the attachment or insertion of the pectoralis major muscle, and teres major is going to insert on the medial lip. Now, there is another thing that apart from these insertions of the muscles, the long head of the bicep also passes through this bicipital groove. Now, on the posterior aspect, the significant landmark is the spiral groove, which you could appreciate over here. Now, this is the spiral groove. From this passes the radial nerve, which is going to supply all of the posterior muscles, that is starting from the triceps. It is going to supply all the extensors and it is going to supply the posterior aspect of the hand and the forearm and the arm. Along with that, the profunda brachii, which is one of the deep branches from the brachial artery, it is going to also lie within this posterior spiral groove. So next up we have the elbow. So elbow is composed of three very specific articulations. So let us have an understanding about this. Now from the anterior aspect, this is the humerus. This is the medial epicondyle, which is always more prominent, and this one will be the lateral epicondyle. This will be the lateral supracondylar ridge. This will be the medial supracondylar ridge. Now here we have the capitulum. Now capitulum is present laterally and it articulates with the radial head, and the articulation will be the capituloradial articulation. Then there is going to be presence of the trochlea on the medial side and it is going to articulate with the trochlear notch of the ulna. Then on the posterior aspect, the olecranon is going to articulate with the olecranon fossa. So these three articulations are very important. So there are certain things which are important. So here we will, on the anterior aspect, we will have the brachial artery which will be passing. So if there is a supracondylar fracture in this region, it can damage the brachial artery. Now, on the posterior aspect of the medial epicondyle, there is going to be the passage of the ulnar nerve, and the radial nerve, when it comes from the posterior aspect to the anterior aspect, it is going to lie in front of the lateral epicondyle. So these relationships are very much important to know. So let's go through the text. So the head of the radius articulates with the capitulum. The trochlea of the humerus articulates with the trochlear notch of the ulna, and the olecranon articulates with the olecranon fossa of the humerus. Now, ulna and radius articulate with each other, and that articulation results into the supination and pronation movement. So we have the superior radioulnar joint and the inferior radioulnar joint, and the movement at these two joints is the supination and pronation. So superior radioulnar joint is between the head of the radius and the radial notch on the ulna. As you could appreciate in this diagram, let me clear some space. So here this radial head is going to articulate with the radial notch of the ulna, and this point is going to be the superior radio-ulnar joint. Similarly, in the distal aspect, we have the head of the ulna which articulates with the ulnar notch on the radius. Just a small overview about the scapula. So anteriorly, we have the subscapular fossa. This one is the supraspinatus fossa. This one is the infraspinatus fossa. These two are present posteriorly. And with respect to the borders, this is the superior border. This is the medial border, and this one will be the lateral border. Now, here in the front, we have the coracoid process, and this one, which is a spine, which is present on the posterior aspect, it is going to curve and come anteriorly, and this portion will be known as the acromion. Now, acromion is going to articulate with the lateral end of the clavicle and form the acromioclavicular joint. Then, with reference to the coracoid, the pec minor, the short head of the biceps, and coracobrachialis takes their origin from this point. And there is another thing that the glenoid cavity, it articulates with the head of the humerus to form the shoulder joint. So this was just about the overview. Rest we have talked in the muscular section. So now we have the carpal bones of the hand. So we have two rows and we are supposed to know their names from lateral to medial. So we have radius and ulna. Radius is present on the lateral side and ulna is present on the medial side. So this one will be the lateral side and this one is the medial side, and we move from lateral to medial. Now the proximal row had scaphoid, lunate, triquetrum and pisiform. And then again we will start from the lateral aspect, that will be the trapezium, trapezoid, capitate and hamate. So now we will talk about certain MCQs or clinical correlates with reference to each of these bones. Scaphoid is one of the largest carpal bones and receives its blood supply in a distal manner. So now from the radial artery, there is going to come blood supply and it is going to enter the scaphoid from the distal aspect. So this one is the distal aspect and this one will be the proximal aspect. So by any reason, if there is a transverse fracture over here and the blood supply cannot reach this proximal part, then this proximal part is likely to develop the avascular necrosis. So it is likely to develop the ischemic necrosis. Scaphoid articulates with 5 bones. Well, that is very important. Let me clear some space. So it is articulating with the radius. It is articulating inferiorly or proximally with the radius, and it is going to be articulating medially with the lunate and superiorly with the capitate, trapezium and trapezoid. Pisiform, which is a proximal row's most medial bone, is a sesamoid bone which is embedded within the muscle, and that muscle is the tendon of the flexor carpi ulnaris. So basically, it is present within the tendon of the flexor carpi ulnaris. So like all these points have been tested, so you need to remember them. So median nerve can get injured in case of lunate dislocation. So we know that median nerve is going to enter in the anterior aspect from the forearm into the hand. It is going to lie almost around over here, and there will be flexor retinaculum over it, and it is passing through the carpal tunnel. Now, if there is by any chance fracture dislocation of lunate, then it can damage the median nerve, and we will discuss about the sensory distribution later on, and then you can relate that what will be or what could be the clinical picture. So you can be tested for a trauma scenario where the patient had a fracture of lunate and they might be testing you that which nerve can get damaged. So hamate's body is related to the flexor digitorum profundus tendon. As you could appreciate that here They will be the tendon of the flexor digitorum profundus. Now, each finger has 3 phalanges except for the thumb, which has 2. So, the sum of all will be 14. So, this is also important to know. So, just an overview about the type of joints. Shoulder joint is a ball and socket joint. Acromioclavicular joint is a plane joint. Elbow joint is a hinge joint. The superior and inferior radioulnar joints are pivot joint, and wrist is the ellipsoidal joint. So just in a short summary, let's talk about the movement. At the shoulder joint, we have the flexion, extension, internal rotation, external rotation, abduction, and adduction. At the acromioclavicular joint, there is only gliding. At the elbow, there is flexion and extension. At the superior inferior radial joint, there is supination and pronation. Similarly, at the wrist, we have the flexion and extension. Along with that, we have the adduction and abduction, which is known as the radial deviation and ulnar deviation, respectively. So next up, we are going to talk about the brachial plexus. So brachial plexus has the root value from C5, C6, C7, C8, and T1. Now these roots are going to result into 3 trunks, like C5 and C6 are going to form the superior trunk. C7 is going to continue as the middle trunk, and C8 and T1 is going to make the inferior trunk. Now all of these trunks divide into anterior and posterior divisions. All the posterior divisions result into the posterior cord. Anterior division from the superior and the middle trunk is going to form the lateral cord, and the anterior division of the inferior trunk is going to continue as the medial cord. So from the roots, there is origin of 2 nerves, like as you could appreciate in this orange color. One is the long thoracic nerve, and this one is the dorsal scapular nerve. Now there are 2 nerves which are going now from these roots. These are the 2 branches. Now from the trunks, there is only superior trunk which is going to give 2 branches. There is no branch from the middle and inferior trunk. And the name is that the nerve to the subclavius, it is going to come from the superior trunk, and the suprascapular nerve is going to come from the superior trunk. Now, this area, which is the trunk and the roots, are present in the posterior triangle of the neck. These divisions are present behind the clavicle, and the cords are related with the second part of the axillary artery. So, basically, they are named with reference to their relationship to the axillary artery. So one which is lateral to axillary artery will be lateral, posterior cord will be posterior to axillary artery, and medial cord will be medial. So let's go through the text. So the root value of brachial plexus is C5, C6, C7, C8 and T1. Out of this, C5 and C6 is going to form the upper trunk, C7 alone contributes to the middle, and C8 and T1 combine to form the lower trunk. Each of them divides into anterior and posterior divisions. All posterior divisions unite to form the posterior cord, and the anterior divisions of the upper and middle trunk unite to form the lateral cord. An anterior division from the lower trunk is going to form the medial cord. Now, nerves arising from the roots, that is the dorsal scapular nerve, and this dorsal scapular nerve is going to supply the rhomboids. There are 2 rhomboids. One is the major and other is the minor. Like basically, these rhomboids are present on the posterior aspect of the scapula. So as the name indicates, dorsal scapular nerve. Now we have the long thoracic nerve, which has the root value of C5, C6 and C7. It supplies the serratus anterior. Now all the roots, they also innervate the scalene muscles as well. Now branches from the upper trunk, that is the suprascapular nerve and the nerve to subclavius. Now this nerve to subclavius is going to supply the subclavius muscle. Now suprascapular nerve is going to supply the supraspinatus and the infraspinatus muscle, which are part of the rotator cuff muscles. So next up we have the chords. So the mnemonic for the medial chord is the M4U. So there are 4 nerves which are going to start with an M. That is the medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, and the medial root of the median nerve. And then we're going to have the ulnar nerve. So from the lateral chord, we have the mnemonic LML. We have the lateral pectoral nerve, the musculocutaneous nerve, and the lateral root of the median nerve. So musculocutaneous nerve is going to have the mnemonic, that is the DBC. It is going to supply the biceps brachialis and coracobrachialis, and later on it is going to become the lateral cutaneous nerve of the forearm. Now with the posterior chord, we have the ulnar as the mnemonic, that is the upper and lower subscapular nerve, nerve to the latissimus dorsi, axillary nerve, and the radial nerve. So radial nerve has a mnemonic, that is the best, which is going to supply the brachioradialis, all the extensors, supinator, and the triceps. So try to focus on these mnemonics. They will be very much helpful in solving the MCQs. Now these two upper and lower subscapular nerves are going to supply the subscapular muscle, which is present on the anterior aspect arising from the subscapularis fossa. So high interior to brachial plexus. Interior to brachial plexus may occur in the form of roots, trunks, or cord injury, which can give rise to clinical picture of multiple nerve injuries. So for example, Pankos tumor, which is the tumor of the apex of the lung, which may grow upwards, causing compression or invasion of the lower trunk, and that is the superior sulcus syndrome. That is the name of that syndrome, and it will injure the posterior cord, and that will have effects with reference to the radial nerve and the axillary nerve. So this is a clinical scenario which can be tested, that if the patient is having a lung cancer and in the apex of the lung there is this tumor, and we know that we have the subclavian vessels and the root of the and different parts of the brachial plexus in close proximity to this part. So if it grows upwards, it can compress the posterior cord, and the nerves, that is the radial nerve and the axillary nerve, will get damaged. So with reference to radial nerve damage, there could be a wrist drop, and with reference to the axillary nerve, there will be failure of the 15 to 90 degree of abduction. There will be weakness of the internal rotation because of damage to the TD is minor, but internal rotation will be present because of the external rotation might get a bit weakened, and there will be loss of the sensations from the badge area. So you need to remember all of these findings. So we have discussed these relationships before. Now the roots are posterior to the scalene anterior muscle in the posterior triangle of the neck. The trunks are related to the subclavian artery, and the divisions are posterior to the medial third of the clavicle, and the cords are related to the axillary artery. So now we will have the discussion about the major nerves or the terminal branches from the brachial plexus. So we have the median nerve. Now median nerve has a very important relationship to the brachial artery, that it initially lies. So median nerve starts lateral to the brachial artery, then it passes in front, and then it becomes medial. So this LAM is going to be the mnemonic for the relationship of median nerve with respect to the brachial artery. Now median nerve is going to supply all the flexors of the forearm except the medial half of the flexor digitorum profundus and flexor carpi ulnaris, because those are supplied by the ulnar nerve. while rest of the muscles, that is the pronator teres, flexor carpi radialis, flexor carpi ulnaris, flexor digitorum superficialis, and the lateral half of the flexor digitorum profundus, pronator quadratus, these all are supplied by the median nerve. Now, anterior anterosseous nerve is one of the nerve which is responsible for supplying the deep flexors, and it is a completely motor nerve. So that can be tested in the MCQ. And there is a recurrent branch and a palmar branch. We will have a discussion about these later on. Now in the ulnar nerve, it starts on the medial aspect of the arm and then it passes posterior to the medial epicondyle, and it gives the deep branch, superficial branch, the dorsal cutaneous branches arises in the mid forearm. Then we have the radial nerve. It starts on the posterior aspect of the arm, then passes through the spiral groove, and then it passes anterior to the lateral epicondyle, and it gives the posterior anterosseous nerve around the neck of the radius. And again, the posterior anterosseous nerve, known as the pin, is a pure motor nerve. It is going to supply all the extensors at the wrist joint. Then it is going to be the superficial branch, which is the sensory branch. Now, musculocutaneous nerve starts on the lateral aspect of the arm and pierces the coracobrachialis muscle, and it supplies the biceps brachii, brachialis, and coracobrachialis, and then later on it becomes the lateral cutaneous nerve of forearm, and it supplies the lateral aspect of the forearm. So here you can appreciate that the ulnar nerve is posterior to the medial epicondyle and the radial nerve is anterior to the lateral epicondyle, and it gives the deep branch that is known as the fin. So next up we have the discussion about the muscles of the upper limb. So you're not supposed to exactly know what is the origin or what is the insertion, but you're supposed to know what is the nerve supply, what is the action, and is there any specific relationship or any specific anatomy point which is related to that muscle. So we'll have that discussion. So first of all, we have the shoulder region. The pec minor is supplied by the medial pectoral nerve. We have discussed that the medial pectoral nerve is coming from the medial cord, and it is going to depress the scapula. Now, important thing with reference to pectoralis minor is that it is going to divide the axillary artery into its three parts, and there is going to be one branch from the first part, there is going to be two branches from the second, and three branches from the third part. We will have a discussion about axillary artery in the vascular section. Now, pectoralis major is supplied by the medial and lateral pectoral nerve. We have discussed that the lateral pectoral nerve will be given off by the lateral cord and the medial one is from the medial cord. Now, it is responsible for the adduction and medial rotation, plus it also assists in the respiration. So this is the extra or the accessory function of pec major. Now, teres major, latissimus dorsi, and pec major, as we have discussed previously, all are inserted in the bicipital groove. So that is its clinical importance. And let's talk about the latissimus dorsi as well. So it is going to be supplied by the thoracodorsal nerve, which is the nerve to the latissimus dorsi, and that is being given by the posterior cord. So basically the purpose of giving you this brainstorming is that this is the way you can be tested on the exam. So latissimus dorsi's function is again adduction and medial rotation, but it is going to be helpful in the extension during climbing and swimming, and we have discussed its clinical relevance with reference to the bicipital groove. Now, latissimus dorsi is present at the base or the floor of the bicipital groove. Now, all the muscles which are present in the bicipital groove, we have discussed that on the medial lip we have the teres major, on the floor we have the latissimus dorsi, on the lateral lip we have the pec major. They are all adductors and the medial rotator. So they are going to pull the arm towards the center of the body, that is the adduction, and towards the rotation will be medial rotation. So then we have the deltoid. It is supplied by the axillary nerve, which is again given by the posterior cord. Now it is responsible for the abduction from 15 to 90 degrees, and it is going to maintain the shoulder contour. Now there are three fibers, that is the anterior fibers, the middle fibers, and the posterior fibers. Anterior fibers are responsible for the flexion, the middle fibers for the abduction, and the posterior fibers for the extension at the shoulder joint. If there is an injury, there will be loss of the shoulder contour and the loss of abduction from 15 to 90 degrees. So serratus anterior is supplied by the long thoracic nerve. Now long thoracic nerve has a root value of C5, C6 and C7, and it is given from the roots. Okay. Now it is responsible for abduction at more than 90 and protraction of the scapula, and its injury is resultant during the breast surgery, and it will result into the winging of the scapula. So the winging of the scapula will be the clinical picture, and it can be asked with reference to the breast surgery, especially the axillary lymph node dissection can be added, that can result into damage to the serratus anterior with reference to long thoracic nerve. Or trapezius, it is supplied by the spinal accessory nerve, and spinal accessory nerve also supplies sternocleidomastoid as well. So trapezius again is responsible for abduction of more than 90, and it is going to cause the shrugging of this shoulder joint. And if there is an injury, then it will be unable to shrug. The patient will be unable to shrug their shoulder. Then we have the rotator cuff muscles. Supraspinatus is supplied and infraspinatus are supplied by the suprascapular nerve. Now this is given by the superior or the upper trunk. Now out of these, the supraspinatus is responsible for initiating the abduction, that is 0 to 15 degrees. Now infraspinatus is responsible for the adduction and lateral rotation. Now teres minor is supplied by the axillary nerve, and infraspinatus and teres minor have again these functions, that is the adduction and lateral rotation. So why they are going to cause lateral rotation? Because they are present on the posterior aspect. So when they rotate, the shoulder will move laterally. Now they support the shoulder joint inferiorly. All of these four muscles, including the subscapularis, which is present anteriorly, and the upper and lower subscapular nerves, which are given from the posterior cord, are going to supply the subscapularis. It is going to cause the medial rotation and the adduction. Now, they are all inserted at the greater tuberosity except the subscapularis, which is inserted on the lesser tuberosity. Now, teres major is supplied by the lower subscapular nerve. It is one of the medial rotator of the shoulder, but it is not a part of the rotator cuff muscles. So now we have the arm muscles. So first of all, we have the biceps. It has two heads. The long head arises from the supraglenoid tubercle and the short head from the coracoid process of the scapula. It inserts on the radial tuberosity, and its action, it is the main flexor. Apart from being the main flexor, it also assists in supination as well. Now, coracobrachialis arises from the coracoid process and inserts on the midshaft humerus, and brachialis arises from the midshaft humerus and inserts on the ulnar tuberosity. Now, these are all supplied by the musculocutaneous nerve. Now, triceps has three heads. The long head arises from the infraglenoid tubercle. The medial and lateral arises from the posterior aspect of the shaft of the humerus. Now, if we take spiral groove as the reference, the one which arises above the spiral groove will be the lateral head, and the one which arises from the posterior aspect of the shaft below the spiral groove will be the medial head. Now, it inserts on the olecranon. It is responsible for the arm extension, and it is supplied by the radial nerve. So as you could appreciate that this is the coracoid process, and it is going to have short head and the coracobrachialis. And from here, the infraglenoid tubercle is going to be the long head of the triceps, and this supraglenoid tubercle is going to give the long head of the biceps muscle. Now, the biceps is going to insert on the radial tuberosity of the radius, and the brachialis muscle is going to insert on the tuberosity present on the ulna, whereas the deltoid muscle is going to be inserted at the radial tuberosity. So you need to remember the difference between these tuberosities. So deltoid will be inserted on this radial tuberosity that is present over here on the humerus. Now in the forearm, the anterior muscles are the flexors, and they are all supplied by the median nerve except 1.5 muscles, which is supplied by the ulnar nerve. Now, any superficialis or brevis inserts on the middle phalanx, and the profundus or the longus inserts on the distal phalanx. So, this is a simple rule to remember. So, this anterior flexors are further divided into two groups, the superficial group and the deep group. Superficial has the pronator teres, FDS, FCU, FCR, and palmaris longus. Now, out of these muscles, only this flexor carpi ulnaris is supplied by the ulnar nerve, and then we have the deep group that is having the pronator quadratus, FDP, and the flexor pollicis longus. Now, the medial half of the flexor digitorum profundus is supplied by the ulnar nerve, whereas the lateral half, pronator quadratus, and FPL are supplied by the median nerve. Now, there is one additional thing, that this deep group, apart from this medial FDP, these 2.5 muscles are supplied by the anterior anterocious nerve, which is one of the complete motor branch of the median nerve. So this FCU and the medial half of FDP are supplied by the ulnar nerves. Now we have the posterior aspect. The muscles are the extensors. Again, they are divided into the superficial group and the deep group. Superficial group has anconeus, brachioradialis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, radialis longus, and radialis brevis. The deep group has supinated extensor indicis, extensor pollicis longus, brevis, and the abductor pollicis longus muscles. Now, all of these muscles are supplied by the radial nerve. Now, out of these, the posterior anterocious nerve, which is the complete motor branch from the radial nerve, is going to supply which muscles? That is the triceps, anconeus, brachioradialis, extensor carpi radialis longus, and the brachialis. Now, from the deep group, these three muscles are going to be making the boundary of the anatomical snuff box. Now, abductor pollicis longus and extensor pollicis brevis are going to form the radial or the lateral boundary, and extensor pollicis longus is going to form the ulnar or the medial boundary. Now, index finger has two extensor tendons, that is the extensor indicis being medial and extensor digitorum being laterally. So, you need to know that which one is present medially and which one is present laterally. It can be tested on the MCQs. So, now we have the hand muscle. So, there are two things that you need to understand. So, first of all, understand the classification or the grouping of the muscles, and then we will learn that which categories are supplied by which nerves. So we have lumbricals, anterocii, thenar group, and the hypothenar group. Now we have this diagram over here which shows that these are the anterocii, which are like present on each part of the tendons. They do not have any bony attachment. And then we have these lumbricals, which are 4 in number. Now, anterocii are further divided into palmar and the dorsal anterocii, and the thenar group has the opponens pollicis, flexor pollicis brevis, abductor pollicis brevis, and adductor pollicis. Now, the hypothenar group has opponens digiti minimi, flexor digiti minimi, and the abductor digiti minimi. Palmar anterocii adducts, so the mnemonic will be the pad, and the dorsal ones abduct, so the mnemonic will be the dab. Now, the middle finger has no attachment for the palmar anterocii, And the function of lumbricals is to provide the pincer movement, that is the flexion of the metacarpophalangeal joint and extension at the interphalangeal joint. This function is very important. So now we will talk that which muscles are supplied by which nerves. Now, with reference to the lumbricals, we have to divide them into medial and the lateral. Now, the medial two are supplied by the ulnar nerve and the lateral two are supplied by the median nerve. All the antroceae, the palmar and dorsal, are supplied by the ulnar nerve. All of the hypothenar eminence is supplied by the ulnar nerve. Now, apart from in the thenar group, only the adductor pollicis is supplied by the ulnar nerve, whereas these three muscles are supplied by the median nerve. Now we have these lateral two lumbricals and these three muscles of the thenar group being supplied by the median nerve. Now there is a bit depth to the branches which can be tested on the exam. Now, the thenar muscles except the adductor pollicis and the lateral two lumbricals are supplied by the recurrent branch of the median nerve. Now, all of these muscles are supplied by the deep branch of the ulnar nerve except the 1.5 muscles of the forearm which are supplied directly by the ulnar nerve. So, these are two further extensions which can be tested. So let's have an overview about the thumb movements. So this movement away from the body will be abduction, towards the body or the center will be adduction. Posterior direction movement will be extension, forward will be flexion, and this movement in which the thumb is touched to the little finger or any other tip of the finger, that will be the opposition, and this position will be the repositioning of the thumb.